That's So the analysis suppose
अब देखिए आवाज आ रही है।
CA ovary stage 3 by virtue of retroperitoneal nodes and not because of the peritoneal disease.
Right.
Then
हेलो हाँ सर
hyphen has the same role in such cases.
No. Because that's the reason that if the peripheral disease is there, that hyphen has got the role. If the nodal disease is there, you the resect the node, you know. So I believe as a surgical oncologist, we should go for this because if you see this stage 3, stage 4 ovarian cancer, there is 70 to 80% nodal involvement is there. Even if you see the line trial, you know, there will be a big with the like I what is the big mystery of this trial. They have seen this thing whether lymph node in the upfront setting, they resected one arm, around 300%, they do the systemic lymphadenopathy, another arm they didn't do it. Even if those lymph node they resected, that is also not clinically seen in this because of the after you know, this is even their node also 55.7% positive. In our series, up to 60% positive after neoadjuvant chemotherapy. So node is a part and parcel of the disease, you know. We have to remove anyway in the advanced ovarian cancer. The systemic lymphadenectomy has to be done, then my view. And because why I am telling that, because in the gynecological cancer, the main principle is that the staging. And staging means you have to remove the node. Unless you remove the node, how do you see this thing, the node is involved or not? So how they violate the basic principle of the gynecological surgery, number one. Number two is that is a safe house of the cancer cell. So you living in the cancer cell, how you can claim that I achieved the CC0? So you cannot claim that one. So you cannot do the hygiene also like that. So my view, even my series, 60% patient after the university that the nodal positivity is there, nodal positivity is there. So you have to remove that. As far the hyphic is concerned, if the recurrence only the node, that is the second common recurrent after the peritoneum, so that is not indicated for this thing in secondary setting the hyphic. Where nodal recurrence, just remove the node. So that is the thing, because you know the ovarian cancer, the beauty is that why this is the node is not coming in the picture. What I feel, like first and foremost thing, patients are dying because of the two reasons. One is the cancer cachexia, with the poor nutrition, because in the second is the intestinal failure. So when the node comes in picture, by the time patients have come, so that's why node is coming. But if the patient having the node and disease node, that is in there, if you see the patient having the cancer inside the body, so immunity is being hampered and patient immunity is going down. So that is not coming in the picture because of this reason. So but this is part and parcel of the disease, we should remove that thing, routinely.
Right.
So hope Dr. Tolini understood this thing, because that is not indication, the known positivity there, that is not indicated for this hypo in recurrent setting. So whether there is not, if peritoneal disease is there, then you should go for the hypo.
If you have any question.
The hyphen started for the 60 minutes. That is also one important thing is there. The 60 minutes and 90 minutes, you know, that is also important. The more because you know all the Protein 7 trial that you highly criticize because they use the 30 minutes. But more you use this thing, the chance of cancer cell the eradication is much more higher, you know. Here I can give you example, like suppose say we use the flow rate around 1000 ml per minute, the flow rate is there. So it varies from the machine to machine, 1000 to 1500 ml also per minute. So 20 to 30% cell is cancer cell irradiated per minute. If you calculate 30 minutes and compare to the 90 minutes, around 6 lakhs times less cancer cell elimination is there. So that is the thing, concept is there. You have to do the 90 minutes always better. More the time you spend, more the elimination of the cancer cell. So that's why Protein 7 also highly criticized because they use only 30 minutes. So we are in between and the logistic issues, so many issues are there, and our patient cannot tolerate for a long time. At least you should keep minimum 60 minutes. So 60 minutes in ovarian cancer, you put 60 minutes. And another one important thing is that regarding the use of the drug, you know, because sometimes we calculate, usually all the trials, particularly the Vontal trial, they use cisplatin 100 milligram per meter square. So in Indian patients, if you use the 100 milligram per meter square, alternate patients will have the renal toxicity. Unless you use this nephroprotective drug like amifostine or sodium thiosulfate. That's why another reason we use the systemic, the 75 milligram per meter square. So that is also acceptable because already other literature, other study also they accepted the 75 milligram per meter square, the systemic dose. So, but one thing is that suppose sometimes you want to use like 90 minutes, then you can divide the dose. In the, suppose you know that so many people like Dutch, they have made a protocol they are using the total drug, mitomycin 30 milligram per meter square. They divide into three steps, first half an hour, the 50% of the total dose, then another half an hour, another 50% of the another remaining dose, and then the last half an hour, another dose. So that reduce the renal toxicity and other the drug-related toxicity. So that is also good thing, but in hypex, sometimes the patient, obese patient is there, urine output low, and then you can do also that way. Because suppose I calculated in this patient 115 milligram total cisplatin. So initial phase I can use 80 milligram. Suppose in half an hour, then I can put another drug in the half an hour like that. Suppose you put 90 minutes, you can divide it into three divided dose. So first half an hour, you have to use the 50% of the total dose. So that is also one way you can adjust the dose. It varies from patient to patient like this way, how to calculate. Every patient is different, I believe, but you have to know all the options. If you know this, then you can use judicially where that's going to use that or how to use.
Sir, this was asked before, but if for any reason we cannot do high-tech, for instance, the patient has a lot of blood loss and is hemodynamically unstable,
Right.
or we don't have adequate urine output in spite of maximum hydration.
Right.
Do you attempt high-tech at a later date, or
Oh, I have the paper of the stage hyping,
yes, high-tech, yes.
The stage hyping patient are also feasible. What happens, because patient is hemodynamic unstable, then you are doing another hypec for another thing that in case those sugar picker doesn't claim that thing is hypex has any kind of morbidity. But we believe in Indian scenario, we see this thing. If the patient in hemodynamic, moral doesn't permit to put the another 1.5 hour, we keep the patient in the OT table and do the hypec line. So what we do after 48 hours. When the patient is stable, when we started doing already after the anesthesia, they are not comfortable with these things. The patient is high inotropic support. We close this thing, we make the patient stable. After 48 hours, we take another this patient for the hypec. If the hypec is required for this patient. So that is also good practice. I think that is also feasible.
Thank you.
We are taking another case like let's hope that is better, but that patient is slightly obese. But let's hope for the best.
Sir, I wanted to ask that in this machine, when they were demonstrating before, they mentioned something about the vibration which they send into the peritoneal cavity.
Right.
So, what is the how that vibration helps for this patient, and why?
What this regarding what vibration?
Yes, sir. They have mentioned in the machine demonstration before,
Right.
but they could not say the significance of that.
So no, that is the vibration is not much more. This is the flow rate is most important. The standard flow rate is there. That should be 1,000 minimum ml per minute. So that should be the minimum flow rate. That is the better thing. I told this because elimination of cells depends on the flow rate of this thing. But if you keep increasing the flow rate, like suppose say 1,500 or 2,000, so the chance of anestotic leak, chance of edema formation of the bowel is much more higher. So you have to make a balance in that. So I always keep in 1,000 to 1,200 ml per minute the flow rate. So that is, I think, in between that is better, not like increasing the cancer cell, but you are doing much more like chance of anestotic leak is there or bowel edema formation is there. So that we should stop that one. We should restrict in that in between 1,000 to 1,500. Maximum the 1,200 is the standard. So vibration part, I don't know. I don't feel anything. So the vibration part, what they are telling in demonstration showing the vibration part sort of. What vibration? Me, madam was asking during demonstration, somebody is showing the some vibration. What vibration? No, nothing like that.
So it demonstrated high autonomy.
Not vibration actually. The flow rate is important.
Thank you.
Hmm.
Sir, one question, sir.
tell me, keep asking.
Sir, if the patient is having a mediastinal lymphadenopathy in this case, and
Right.
after neoadjuvant chemotherapy, the lymph nodes has responded, and PET scan is showing no uptake or in that,
Right.
does that patient can be considered for
So there is a kind of gray area, there is no clear cut answer kind of thing, but I can logically demonstrate because of my experience, because if you see the ovarian cancer biology, that is normally 97% that is confined to the abdominal cavity, hardly it goes to the lung sort of thing, is there mediastinum. And these cases, like if a mediastinum node is there, if the good response is there, so like that is kind of gray area, no had a clear cut guideline is there, but we are doing this thing CRS and IP because maximum disease if you can remove from this thing and patient survival is prolonged despite of lymph node in the mediastinum. So I see this one, that's why we do this thing, in their case also we do. But truly speaking, there is no guideline, no much more literature is there. The what exactly to be done, that is not nothing is there. Like in the cardiophoning node, because there's not much more literature is there, but they say in the cardiophoning node involvement is there, that is poor prognostic. So you can say slightly poor prognostic, but that doesn't mean like you cannot go for this CRS and hyper for that. So we do usually.
focus? And sir, for the bowel anastomosis, sir, does the staple anastomosis and hands one make any difference in post-operative?
But that is actually what happens, there is no much more difference is there, but if you see the literature, they say that is more good if you do this like staple anastomosis. And hands-on anastomosis, sometime in the lower anastomosis when the chance of leak is there. So that is not kind of a clear-cut thing is there, but anything if you do the good, you are confident enough, you hands-on, I think that is equal to my view. But as for the literature, that staple anastomosis is better in compared to the hands-on anastomosis. That's actually because they actually suppose that's why I take always because that depends on the edema and timing. If you just keep the mood timing, temperature in range always towards the 43 and above, the chance of anastomotic leak is high. Even if you use the mitomycin also. So this kind of thing you have to take care. Sometimes what happens in the anesthesia, suppose I say this anterior resection, I keep that part slightly away from this because there is no question of margin. So why to put unnecessary into this thing as a chance of anastomotic leak is there. But not only even if you do that, you have to do the another diversion. So another surgery is there. So this kind of thing you have to calculate like this. In good high quality albumin level is there, patient GN condition is good. So that is in that case I never vasculated goes and particularly you are satisfied with the anastomosis. So I never do this diversion all right. No.